Good evening and welcome back to HKL RT series, Radiation in Hematological Malignancies. I'm Dr. Ananda Kumar Balakrishnan, clinical oncologist from Hospital Kuala Lumpur, and I will be presenting now on extranodal NKT cell lymphoma. So this is the publication from ILROC on the management of NKT cell lymphoma. So NKT cell lymphoma is an aggressive disease and is often associated with EBV infection. It can originate from any parts of the body, most commonly seen in the upper aerodigestive tract, and we also do see them in other sites as well. We'll look into a bit on the subtypes of NKT cell lymphoma. We have the nasal type, the non-nasal type, and the other types as well. All of them are predominantly around the age of 40s and 50s, predominant in males. And so in terms of lymph node, regional lymph node involvement, they differ. So it's a bit uncommon for the nasal type, up to 80% in the nasopharynx, oropharynx type, and commonly also seen in the other sites, depending on where they arise from. Prognosis is usually favorable for the nasal type and more poorer prognosis for the other sites. So Ann Arbor classification or Ann Arbor staging system is also used in NKT cell lymphoma. About 17 to 90% of them present in stage 1 and stage 2, whereas about 10 to 30% present in advanced stages. PET-CT and MRI plays an important role in staging as well as guiding in radiotherapy delineation. So the nomogram revised risk index is used to stratify patients into low, intermediate, and high risk group. We'll look first into the nasal ENKT cell lymphoma. So the nasal NKT cell lymphoma has a tendency of invading surrounding structures, but less chances of lymph node involvement. So in cases where in PET-CT or MRI there's a uptake or enhancement of showing involvement of retropharyngeal nodes, CTV should include the retropharyngeal nodes and also bilateral level 2 nodes. And for stage 2 NKT cell lymphoma with positive cervical lymph nodes, the CTV should include bilateral cervical lymph nodes. Okay, so let's go in. This is a good guide that is actually published in the paper, the ILROC paper for NKT cell lymphoma. So as for the CTV for nasal NKT cell lymphoma, so it should include the GTV with a 5 mm margin all around and all the high risk regions. So for patients who the tumor is only confined to the nasal cavity, the entire nasal cavity should be included in the CTV. Ipsilateral medial maxillary walls bilaterally should be included. Anterior ethmoid sinus in the superior region, and the inferior should include the hard palate. Posteriorly, the nasal aperture should be included as well. This is an example of a stage 1 nasal NKT cell lymphoma and the contouring for it. So the GTV is the tumor that is located close to the medial wall of the left maxilla and is actually including and involving the area of the nasolacrimal duct. And the blue outline is actually showing the area of the CTV. So this CTV is including both sides of the medial wall, and as this GTV is already involving the medial wall of the left maxilla, so we give a bit of a margin about 5 mm around to include the ipsilateral maxilla in. And these are the lower slices, so all the way up to the area of the hard palate. And yeah, this is the sagittal view and the coronal view of the contouring. Next, we're going to look into stage 1 nasal ENKT cell lymphoma with primary tumor invasion. So it's not purely confined to the nasopharynx. So if the primary tumor of the nasal disease is close to the posterior nasal aperture and invades into the nasopharynx. So we need to include the entire nasopharynx. Or if the tumors are extending into the anterior ethmoid sinus or the posterior ethmoid sinus, so we need to include the entire posterior ethmoid sinus. If the maxillary sinus is involved, either partially or completely, the whole maxillary sinus ipsilateral should be in the CTV. If the primary tumor invades the subcutaneous soft tissue of the facial skin, so to include the involved facial subcutaneous tissue with a bolus of 0.5 to 1 centimeter in the contouring. If the orbit is involved, so the orbital GTV with a 3 mm margin, normal structure of the orbital cavity that were clearly uninvolved uh, through, even though it's actually displaced by the GTV, needs to be excluded. So this is based on clinical judgment and also with pre-chemotherapy assessment. So it's very important to actually get ophthalmological visual assessment for patients who have extension into the orbit. So this is an example of stage 1 NKT cell. This is a tumor on the right nasal cavity involving and invading into the right maxilla. So you can see that the CTV is actually outlined in blue, including the entire maxilla on the right, the medial left maxillary wall, and the entire nasal cavity. For this patient, we can also see that the tumor at the lowest medial slice is extending and invading into the nasopharynx. So, as based on what was recommended, the entire nasopharynx is also included in this case. Next, we're going to talk a bit about CTV of lymph node. That prophylactic lymph node irradiation in nasal NKT cell lymphoma is not recommended if there is no gross lymph node involved. But as we mentioned earlier, if there is retropharyngeal node involvement or positivity, both of the retropharyngeal nodes need to be included in the CTV. And if there is a positive cervical node, then bilateral cervical nodes need to be contoured. Now we go into non-nasal NKT. Non-nasal NKT cell usually is multi-site with up to 60 to 80% of regional lymph node involvement. Commonly involves the area around the Valdeir ring, which is very rich in lymphatic drainage. So the Valdeir ring, if you can see in the picture, involves the nasal tonsil, the tubal tonsil, palatine tonsil, and the lingual tonsil. So prophylactic cervical lymph node irradiation in non-nasal upper aerodigestive NKT cell is quite controversial. But the prophylactic irradiation of the neck need to be considered if the tumor is actually invading into the Valdeir ring, as we have seen before. So this is a single institutional Chinese study, a retrospective study in stage 1 Valdeir ring ENKT cell lymphoma who did not receive prophylactic neck node radiation. It shows that it has a high recurrence rate of cervical node recurrence up to about 27.3%. So let's go to the contouring guideline. So for primary disease in the Valdeir's ring, single or multi-site, the whole Valdeir ring, the nasopharynx, the tonsil, the tongue base, the oropharyngeal walls need to be included, including the posterior nasal aperture as well, and any other adjacent organs that is involved. If the disease is in the oral cavity, larynx or hypopharynx, the entire structure with the adjacent soft tissue involvement with at least a 2 centimeter margin all around should be included for the CTV. In terms of lymph node, if there is no lymph node involvement, prophylactic neck node can be considered. It's up to the physician's or the radiation oncologist's discretion. So clinical judgment is important. And if the cervical nodes are positive, definitely bilateral cervical node needs to be irradiated. So here we can see this is a nasopharyngeal NKT cell. So the red outline is actually the gross tumor encompassing the entire nasopharynx. So 5 centimeter margin is given all around the nasopharynx and including the areas that is mentioned before in the Valdeir rings as well. So because this is a nasopharyngeal NKT cell, we are including the neck nodes as well, all the way down to level 4. So this is another example of a non-nasal upper aerodigestive tract ENKT cell lymphoma. So this is a tumor in the left tonsil, and there are multiple gross cervical lymphadenopathies as shown in the picture. So this we are giving a 5 millimeter, sorry, all around expansion with including all the critical structures as mentioned, and covering the node levels up to level 5. So if you can see here, the author has nicely evaded the uninvolved submandibular gland. So in this kind of cases, this submandibular gland needs to reach a mean dose of less than 11. So for NKT cells that are arising from areas not from the upper aerodigestive tract, the recommendation, if it's a cutaneous lesion or soft tissue lesion, we should give a margin at least more than 2 centimeter all around, and the adjacent organ, if it is involved, should be included. If it's a stomach disease, the entire stomach needs to be included, including the adjacent soft tissue that was involved. Prophylactic lymph node is not necessary if there is no gross node involvement, but if there's regional lymph node positivity, then the regional lymph node should be covered. Hence, proper imaging such as MRI or PET-CT scan is really crucial in NKT cell lymphoma. TV expansion for upper aerodigestive tract NKT cell lymphoma is about 0.3 to 0.5 cm around the CTV, and for other sites is 0.5 to 1 centimeter all around. So because NKT cell lymphoma is chemo-resistant and radiosensitive, but it's not as radiosensitive as Hodgkin lymphoma or other B-cell lymphomas, hence the recommended dose of treatment for the primary tumor is up to 50 Ks in 25 fractions, and the prophylactic node area can be treated to a lower dose from 40 to 45 Ks. Thank you.